एप्लीकेशन आता है। अब तुमने एप्लीकेशन बंद करके फुल स्क्रीन किया उसको?
देख रहा हूँ। नहीं, वो मैंने उसको एग्जिट किया, मैंने कहा लो फिर जरा उसको करें। अरे वो मालूम है मेरे को, मैंने एप्लीकेशन ही शेयर करी है।
एप्लीकेशन वहाँ ये शेयर है ना, जो खुला हुआ है ये, इसमें आप वो पिक्चर नहीं दिख रही है। वो पिक्चर तुमने बाहर से अलग से खोल दी है दूसरी, तो वो तुमने दिखाया।
अरे यार बड़ी समस्या।
भैया फोन आ रहा है।
Hello.
लास्ट मिनट क्यों डिसाइड हो रहा है?
Morning, Dr. Professor Sadapati.
Hello, good morning.
Good
Can
morning,
you hear
good
me?
morning.
Can you see me?
I can see you. I can-
Yeah, just 1 second. Yeah, we're just removing the banner.
Okay.
And
Yes, sir, you are seen.
yeah, we all see you.
Okay, fine, fine. Can I just share my screen for a minute to confirm that I'm getting it?
Do quickly because we'll start in 2 minutes. Yeah.
Okay. You're able to see it?
Yeah, we can do it. We can see it. Okay.
Okay.
आप वहाँ mic है वहाँ पे ठीक. So in 2 minutes we're going to start. In my watch it is another 2 minutes. So we are now getting connected to our faculty, also connected to our IEC members. We can see Madam Salin Mathur, Mr. Gautam Palit, and Dr. Mitra is here, our senior professor in KGMU, and Benita is already here. He is the host actually. And I can see Dr. Sraf there, Dr. Mahanti and Dr. Ganpati, our speakers are all on. Dr. Mahanti, welcome. Dr. Sraf, welcome. Okay.
Thank you.
So now, yeah. So we'll be ready now, and I was just waiting for a director, and he's already there. I think in just 1 minute, I think we should be able to connect him. So this is a very kind of welcome attitude that we find from the IC, our Institutional Ethics Committee. All of you have your IC in your own institution. They take up the research projects and all these things in the drug trials. But this is an exceptional, they have done it. They're addressing the issue of the telemedicine, telehealth, because that is being happening so much in this country. So this will be my beginning, and we are going to discuss a lot about art in the telemedicine, the dedicated symposium that this year. So I think this is very relevant for the time, especially during COVID. It is all rampant. Everybody is free to do whatever they like, the way they would like, and define the telemedicine the way they feel. So, so now I request Dr. Benita Agarwal, Professor of Pathology, who is our member secretary of the Institutional Ethics Committee, to take over and conduct this session. Yeah. Yeah. To welcome Professor Sk Dhiman, our director. He's already there. So now, welcome, sir. And we have all the three invited faculty. I think many of them you know also. You know Professor Sunil Sraf, who is very active in the transplant domain. And Professor Mahanti is from the Sk Medical College, Cuttack, a veteran in telemedicine there in Odisha. And Professor Ganapati, he's a neurosurgeon. He's just another veteran. So we have caught hold of all the people having extensive experience in telemedicine to be experts in this session. So I request Professor Benita to start this session.
Respected Director, Sir, Professor Sk Dhiman, Professor Sk Mishra, the Emeritus Scientist of the ICMR, faculty for the webinar and participants. I request Dr. Dhiman to kindly welcome all our participants for the webinar today. Dr. Dhiman, please, sir.
Thank you, Dr. Vinita, and also the congratulations to you for organizing such a very important topic, that is the ethical issues in the telehealth practice. I would say that the ethical issues, they are all really very important, but most important is nowadays, in the current scenario of the COVID, the telehealth practice or services that we are providing. And I tell you very frankly that I have an experience of the telemedicine practice while I was in Chandigarh, and particularly we were treating the chronic hepatitis C patients all over the state of the Punjab also. And we created 25 centers, and we were made the capacity building also of the doctors, nursing staff and others also. And we treated all these patients at the, I would say, local level, village level, or at the district hospital level. And by the time I shifted this place, we treated almost 1 lakh patients. So this is the power of the telemedicine or telehealth practices, or in other forms also, the ECHO also, program also. But at the same time, there are the issues also related to the ethical issues related to the telemedicine. And of course, there has to be a doctors and the patient relationship that has to be maintained. And most important is the data confidentiality as well as the data security. So I think we are going to listen from our experts, and you have experts from all over India also. And we have to deliberate also when we are treating or we are informing something or doing some kind of procedure, not immediately thereafter taking the informed consent and other things that we have to deliberate upon also, as well as then we have to note about the ethical issues concerned about the satisfaction of the patient as well as the family. With all these small comments I invite each one of the faculty or the experts in the field. I know Professor Sunil Shroff, I met him several times also. He has been the front runner as far as the organ donation is concerned. And Professor Sk Mishra, our own professor from the institute also, and he has done a lot of work as far as the telemedicine is concerned. And he has created the School of the Telemedicine and the BMI at the institute also. And that has the national recognition, most importantly. And even after his retirement, I would congratulate and I would appreciate also that he is more active than before, at least in this field also. And Professor Ganpati, I welcome you from the Apollo Telemedicine Network Foundation. And lastly, the Professor B.N. Mohanty, who is the honorary advisor to the government of the Odisha, for joining us for this very important seminar or the webinar, I would say, that is the ethical issues in the telehealth practices. With all the comments, I would like to close now. Thank you so much. Over to Dr. Vinita.
Thank you, sir, for your words. I would like to give a background of this course. I've been asked to talk about it. So this is as per the directives of the Honorable Minister of Medical Education. We have been conducting a series of programs on medical ethics once a month since July 2020. That is last year. We have been sharing experiences, challenges, and ethical issues during the COVID-19 pandemic, which were experienced by our healthcare professionals, laboratory professionals, patients, and children from the campus. We have also discussed issues which are related to the community, including responsibilities and conduct during the pandemic, vaccination hesitancy, etc. SGPGI as an institute also conducts 01 and 02 courses, which is important for the training and for making our students aware of the different aspects. So this is a new initiative. This is being started as a 01 course. It has been designed to provide an understanding of principles of medical ethics related to biomedical research and also to clinical practice. It will be conducted once a month once a month on a Saturday. So there will be 12 different topics which will be covered. And we start with discussing one of the most important issues, especially in this COVID-19 pandemic, that is an ethical issues in telehealth practice. We know that COVID-19 pandemic has accelerated the use of telehealth globally, and it has a power to change from sick care to healthcare type of a perspective. And with the technology in our hands, with our mobile being also telemedicine and telehealth savvy, the possibilities are limitless, but we need to also understand that with great power, there comes greater responsibility. So we thought of conducting this seminar, and to address these ethical concerns, it is important for the future development and deployment of these techniques. With these words, I also thank Professor Sk Mishra for the planning and putting the program together with an expert panel of national faculty in the field. We have 4 experts. Dr. Dhiman has already introduced. Each expert will be talking on the topic for about 15 minutes. First of all, we have Professor Sk Mishra. He needs no introduction. He is an endocrine surgeon who has spent 3 decades in developing an emerging surgical subspecialty in our institute. He is very passionate about technology, we all know, and he has adopted it in the health system, in particular the information and communication technology. Besides setting up a telemedicine training and research facility in SGPGI campus with grant and aid from the support of the government of Uttar Pradesh and government of India, he has been instrumental and contributed throughout the country and developed a wide network of telemedicine in different countries also. His academic contribution to the field of telemedicine and digital health and his vast experience made him capable to deploy some of the large national and state telemedicine enterprise networks. Currently, he is involved in telemedicine research as ICMR Emeritus Scientist at the School of Telemedicine and Biomedical Informatics. I request Dr. Sk Mishra to kindly introduce the first speaker, Professor Sunil Shroff.
First is Ganpati. So, okay. Good morning and thank you, Binita. And Professor Sunil Shroff has just been briefly introduced by our director. And I'd like to just mention that he is basically he is a trained urologist. So he was earlier professor and head of the urology and transplantation in SRMC Chennai. After taking a long stay in UK, he came back and took over that position. And he continued for a long time in that SRMC. So during that time, I came to know about him maybe early 2000. And in 2001, we had the first national conference in which he was invited. During that time, he was president of the Medical Computer Society. So he is into computing and ICT in the healthcare for many, many years. So one of the veterans in our country. And we engaged him many times in events here in Lucknow. At the same time, he came into the administrative responsibility of the Telemedicine Society of India, besides taking a lot of responsibility in academic programs of the Telemedicine Society of India. Currently, he is holding that responsibility in the Telemedicine Society of India. And besides being the president of the Tamil Nadu chapter of the Telemedicine Society of India. So needless to say that he has achieved the peak in the academic career, and he has a number of publications and most preferred invited lectures in his own field, and now of course in the field of the telemedicine and digital health. So he's very active in the organ donation program. Our director just mentioned about that. He's heading a Mohan Foundation in Chennai, and he's into this national program as well as the state programs related to organ donation program. So with that introduction, I request Professor Sunil Shroff to give his presentation.
Thank you very much, Dr. Mishra, and thank you, Dr. Deba. Great pleasure to be seeing you again after so long. We are still celebrating the Organ Donation Week. That's why I have my green ribbon on my label. A lot of programs going on in this week. So thank you for the introduction, and I'm going to start off the talk with the scope of telehealth services with a legal and ethical perspective. Just to very briefly tell the viewers that telemedicine is nothing but some technology which helps the doctor and patient to meet when the patient cannot meet the doctor physically. What it also means is that with the doctor and patient, the health laws and ethics will apply, technology with technology laws will apply. And this is what leads to telemedicine. And this is going to be the discussion for the next 15 minutes. So if you look at the scope of telehealth services, it will depend on the timing of information transmitted. Whether information is being transmitted real time or asynchronous or not real time. So depending on that, your scope of telehealth services will be decided. Today, with 4G available and 5G coming, synchronous is becoming more and more popular, but asynchronous has a lot of roles still to play, especially with email, second opinions, the images being transferred and so on. So when you combine both synchronous and asynchronous, you get these apps, software and applications, which actually are the way forward that the government of India hopes that telemedicine will take off in the country. The scope of telehealth services also is a function of bandwidth, latency and complexity of care. This slide I've taken from Oxford and very beautifully describes that according to the scope of your telehealth services, if you want to go for high definition video kind of procedures, then you require a very high bandwidth, low latency. But if you require only to do email consultation, then asynchronous or low bandwidth is enough. And if you want to do a video quality, then again, a middle level bandwidth is required. There may be a little bit of latency, but that doesn't matter. So this slide very beautifully projects the scope of telehealth services and the scope of technology in providing those services. So let's look at the telemedicine laws that apply in India. The Indian Medical Council Professional Conduct Etiquette and Ethics Act and telemedicine, how that kind of comes in, and scope of implementing teleservices from ethical consideration in implementing the telemedicine practice guidelines, which has been given by the Government of India. If you look at the health laws which apply for telehealth services, the Indian Medical Council Act, which I already told you about, the Professional Conduct and Etiquette Act will apply, and this includes the telemedicine practice guidelines. Then, by the way, it is the chapter 3.81 of that act in which the telemedicine is included in Appendix 5. Then the Drugs and Cosmetic Act of 1940 will apply. That's a drug list in telemedicine practices. Then the Clinical Establishment Act will apply. The ICT laws, various laws like in IT Act will apply of 2000. Then the Information Technology Intermediaries Guidelines will apply. Telecom law will apply. But in none of these laws as such, telemedicine or digital health has so far been included or mentioned. It will be required when hardware and software is being spoken about. When you talk about malpractices law that apply, for endangering life, section 336, for causing hurt or grievous hurt, endangering life or personal safety, section 337 or IPC 338 will apply. The most dreaded law is the death by negligence, 341A, and is the most dreaded, and that will apply. The Indian Medical Council Act has 8 chapters, but the chapters which are important from telemedicine includes this chapter 1, 2, 3, and chapter 6. When we become doctors, we take this oath and we sign this. We are supposed to sign this. I shall abide by the code of medical ethics as enunciated in this act. And it actually says everything in the all the 7 chapters you need to be familiar with. The scope of telehealth implementing services, when you look at, you will look at cross-state telemedicine practice, whether it's allowed or not, standard of care as defined in the practice guidelines, the role of intermediaries and consent process, how long to preserve the records, confidentiality, breach, and advertising. What does it say? So what does the MCI or NMC law says about cross-border, cross-state telehealth consultation? It says that if you are registered with the state medical register or Indian medical register under the Indian Medical Council Act of 1956, then you can practice anywhere in this country, no problem. And there was actually something which went to Supreme Court on this, and the Supreme Court also very clearly said the same thing, that you can practice anywhere in the country once you are registered in one place. So this will work well for telemedicine practice, so we don't have to worry about this area. As far as standard of care is concerned, this is a bit of a worry. The telemedicine practice guidelines say the RMP will uphold the same standard of care as in face-to-face or in-person consultation, but within the intrinsic limit of telemedicine. What it does is, it actually doesn't, standard of care is not well defined in the telemedicine practice guidelines, and the interpretation can be very ambiguous. And this is a bit of a worry. The scope of practice, practice and limitation of telemedicine needs definitely better definition, because standard of care will depend on experience of the professional has, the training a professional has, how many times they do knowledge updation, and no two similar situations are alike. And when there is a case in the court of law of, against a doctor, then when you look at standard of care, this will be, whether it's breached or not, will be determined by the, by the opposition party, by the trier of fact, and the judge. And the judgment can vary depending on how the standard of care is presented. Because sometimes a serious complication can only be visible to a doctor retrospectively that the judgment was wrong. So it is not so easy when you talk about standard of care. As far as informed consent is concerned, the language of consent and the terms and conditions, especially in the apps, are not easy to understand. They are basically completed legal jargon as far as doctor is concerned. And the consumer will be invited to download, the doctor will be invited to download these terms and just say, I accept and go forward. Now, whereas when you do medical research, this is informed consent is very well defined, whether it is with the patients, and it protects the subject very well. We all know that. The scope of implementing teleservices as far as the intermediary or the app developers and software developers is concerned and the liability issues, who will bear the liability issue? Because at the moment, the IT app company for consultation is considered to be an intermediary, despite being a beneficiary. So usually they charge a facilitation fees, but is not liable under the rules regulating the practice of telemedicine. So this needs to be better defined. What about the liability issues with online pharmacies? They are considered to be aggregators and they cannot be prosecuted. So this again needs to be defined. So there are these gray areas which we need to have better kind of clarity as we go forward. When you're consulting, a patient is consulting and the documents needs to be preserved. How long should it be preserved? The guidelines itself say it is incumbent on RMP to maintain the following records and hard copy of the document for a period as prescribed from time to time. It doesn't say anything further than that. So that's why you go back to our, the Etiquette and Ethics Act of MCI, and there it says that it should be preserved for 3 years, and I'll come to that. But as far as telemedicine is concerned, you need to actually keep the logs, the phone logs, email records, the chat records, video interaction logs, not the actual video interaction as far as telemedicine is concerned. So this is what you need to preserve, the logs, and you can capture the video image for patient identification, but you don't need to record the whole video conversation. And prescription needs to be preserved for a very long time. The patient's records, document, images, diagnostic data again needs to be for teleconsult needs to be preserved. And you need to inform the patient and seek permission before capturing the images for storage. If you look at as I said, our act, our MCI Act, it says every physician shall maintain the record for 3 years from date of commencement of treatment. So this is what we are proposing in telemedicine when we also do a training. And if there is a request, then within 72 hours, you have to reproduce the same. And also this, interestingly, the 1.33 says that, 1.34 says efforts should be made to computerize your medical records for quick retrieval. So there is already a clause in our, MCI and NMC Act on preservation and on computerizing your medical records. There are many certificates which a doctor has to, if you are going to issue this certificate, all the certificates needs to be preserved. As far as image is concerned, from video capturing, a psychiatrist, if he's doing a consultation, let's say, and there is a seizure or an abnormal behavior, he may want to capture that. A radiology image may be captured, a lesion of the skin, oral cavity may be captured, but always inform the patient and seek permission before capturing such images. What about privacy and confidentiality issues, which was being talked about earlier by Dr. Dimon? Digital consult will leave an electronic footprint, and it is prone to issues of security and confidentiality. And because video consultation are never going to be 100% confidential. Both doctors and technicians are part of the teleconsultation process. There can be also flaws in the technical equipment. So, what do you do about that? Because the MCI Act says on this that on confidences concerning individual or domestic life entrusted by patient to a physician and defects in the disposition or character of the patient observed during medical attendance should never be revealed unless their revelation is required by the state of law. So our law is very clear, but with teleconsultation, you cannot have 100% confidentiality. And this clarification needs to be done in Chapter 2.2. We need to further have a consultation. Further have something written here to be more kind of, feel more confidence when we're doing teleconsultation. What about emergency services and the scope of teleconsultation? You can give first aid advice as said by TPT, but also you can inform the local police, ambulance service for emergency intervention to save a patient's life. Or, if there is a homicide or attempt to suicide, then you should be able to do that. Now comes to the Chapter 6, unethical acts, especially about advertising. This is another gray area which we have to tackle in our law and in our TPT, in our telemedicine practice guideline. What is advertisement? There are 3 components. Information is allowed. Persuasion. both cognitively or emotionally is not allowed in advertising. And to remind, this is not allowed. So advertising consists of three things: inform, persuade, and to remind. You can inform, you can remind, but don't persuade. That is not allowed in the law. And the TPG itself says the soliciting the patient directly or indirectly by a physician, by a group of physicians, or an institution or organization is unethical. This is what NMC says, the MCI says, the TPJ says, same thing: do not solicit or advertise or give inducement for teleconsultation. RMP should not insist on telemedicine when patient is willing to come for in-person consultation. So a medical practitioner is permitted to make certain things and certain things is not permitted to do. What is he allowed to do? He is allowed to advertise on starting a practice, change of type of practice, change of address, temporary absence from duty, resumption to another place, public declaration of charges, and so on. What is not allowed is printing of self-photographs and publicity and so on. But we know there are a lot of print media has a lot of doctors' photographs, a lot of editorials come up in the newspapers, in the television, but so far no one has been prosecuted. So why have this area? If there is, we are not following it in the, in principle. So this needs again to be addressed in our NMC, MCI Act as such. Prescription medication. Now there is a word called etc. all over the place in this. There's no clarity. Why can't this be, the list be better enlarged? This again doesn't give confidence to doctors. And this is a point of, discussion in all the training programs which you do. What does this etc. mean? How do we interpret this? So we need more clarity in this area as well, if you want to improve the scope of telehealth services. One of the issues is a great amount of digital illiteracy about medical ethics and law. It is not only with the public, but also with the doctor, especially the lack of awareness regarding privacy concern, risk assessment, societal impact, regulatory requirements, and so on. And many of these funding, people like the VCs, the technologists, the data scientists, who invest in health technology have no idea of these kind of ethics and law. So a lot of things are, kind of the regulations are, kind of overlooked when they launch these services. And the biggest danger of digital illiteracy is false sense of security. I have had this problem. In this COVID pandemic, I have had patients who I know have cancer, who needs a prosthetic biopsy, and I've told them repeatedly, please come and have a biopsy in the hospital. They will not come. They'll say, Dr. Saab, let the pandemic stop, then only I'll come. So they do a teleconsultation and it gives them a false sense of security. Doctor has given some advice. So this is one of the dangers which I have realized of the digital literacy in this pandemic. So this false sense of security is something which we need to look at and can be detrimental in providing healthcare and can limit the scope of teleservices. So this is my last slide. So in summary, the scope of teleservices requires more clarity. Amendments are required in the Professional Conduct Etiquette and Ethics Act, the Drugs Cosmetic Act, and ADI Acts. We need more clarity on limitation of what defines standard of care in teleconsultation. The liability of intermediaries and aggregators does not exist. It needs to be better defined. Video consultations, more clarity on privacy and confidentiality issues is required. Publishing of photographs for doctors or making announcement needs further clarification. List of drugs need to be spelled out properly. What can be given, what can't be given. The current act excludes government offices from its purview. Not sure why this has been done. So a lot of these things need to be addressed so that we can improve the scope of teleservices and doctors out there can embrace this technology without any fear as we go forward. So thank you very much. And I look forward to listening to other speakers. Thank you.
Thank you, Dr. Shroff. That was a really nice overview of all the laws which are prevailing and also the caveats which are there in these laws. Thank you, sir. We will take up the questions and the comments at the end of all the 4 talks. Now we move on to the second talk by Professor Sk Mishra. He needs no introduction. We have already discussed about him. He has been an achiever in his own fields, both as an endocrine surgeon and also as for establishment of telemedicine services all over India and in the institute. I request Professor Sk Mishra to talk about the ethical aspects of telemedicine and telehealth. Dr. Mishra.
Thank you, Dr. Binta. Thanks all the audience and on the faculty member here. This topic is liable to be a little overlap, so I just declare in the beginning, but we'll try to avoid overlaps. This also is shared with all our faculty colleagues. So please bear with that. And we'll find out how ethical challenges that we face in practice of telemedicine and telehealth. What I will be covering on the challenges, I will not go for any guidelines, etc. That is the domain of Professor Ganpati. With rapid adoption of technologies in healthcare delivery, it is less constrained with the geography and nationality or even by the institutional boundaries. All of us know about it in the recent COVID times.
Dr. Mishra, can you make it full screen, please?
Okay, sorry for that. Some aspects of the healthcare process are now shifted from the medical centers back into the home and communities. We talk about telehome care and population health. Telehealth applications intended for health promotion, social services, and other activities besides the clinical application of telemedicine or telehealth. So it is now more for wellness and while addressing the illness aspect also. Now, the health information websites, online support groups, automated telephone counseling, interactive health promotion programs, and electronic mail exchanges that have become order of the day. All these things are now covered with the telehealth services. Growth of consumer health informatics. Best example that we see in our COVID times for the last 1.5 years or 2 years. So many companies have come up, startup companies have come up. At the same time, we have several questions about their ethical aspects, but we all adopt it and we all accept it. So any individual can seek medical care or information, are able to find various health information resources that take advantage of new information technology. There are companies, they request doctors. I also got many requests that to be part of their group to deliver this kind of services. Now, before I go further, I'd like to just tell the audience that a lot of definitions and a lot of terminologies are there, which creates a lot of confusion. It's all the same in different, served in different platter, but at the same time, there are minor differences. So I'll just go to the two things. One is telemedicine and telehealth. I leave aside the M-health, E-health, and digital health, so on and so forth. So these two terms are used more frequently. So telehealth is the use of electronic information and telecom technologies to support long-distance clinical healthcare. Patient and professionals are health-related education, public health, and health administration. So if you can see here, it covers a wide gamut of applications in the arena using the ICT. At the same time, let us look at what is the distinction between telemedicine and telehealth. They have been used interchangeably, but I think you should know about it. There's a little difference because telehealth broadly covers a very large area, where telemedicine covers in a small area. So, and digital health again, a very broad area. So here, what happens actually in telemedicine, the doctor has to be there. Whereas in telehealth, doctor may not be there. Because, for example, you are accessing some sites or some companies are giving us some service, the doctor not being there. There are many some services where there is no need of a doctor to be there. So telehealth and telemedicine differs in that, but both the things common is they use ICT, that is information technology as well as communication technology, and distance is a factor for both the services, where the service provider as well as the service seekers are separate. So these two are common denominator for both the things. Like telephone, linking telephone, video, text mail, home computers, and other low-cost technology to various services to facilitate exchange of the health-related information. It can be store and forward systems of telehealth service. At the same time, we have got very advanced applications like real-time applications of telemedicine, like video consultations interactively, and also same time you have real-time tele-interventions, whether it is a telesurgery or any other interventional procedures are being done. You might have heard about a couple of months ago, there was angioplasty done remotely. So any kind of intervention also is possible now with robotic and robotic assisted devices. So what I mean to say is that it's very important to know that the old technology of store and forward still valid today. Like a pathology or radiology, all the applications, you don't need to be in real time. You can just leave the images, somebody can report and give you the report. Now let's define what is ethics. I mean, a lot of people are being researchers, of medical ethics. And it is a kind of thing that anybody can define in any other way you like in ethics. So I just picked up one definition from a dictionary, and it's an attempt to define that common definition of ethics to the medical ethics. But at the same time, ethics are the rules of conduct recognized in respect to a particular class of human actions or particular group or culture that constitute a system of moral principles. But at the same time, there is a very thin margin between morality and ethics. They can be separate also. So I'm not going to detail about that. There are kind of chapters written about that. But what is more important is what Professor Sunil has just said about our ethical practices in the medicine. So professional ethics is very important. It's a systematic application of moral principles through uniform rules of the conduct that we practice day by day with the Hippocratic oath. And let us come to the focus of discussion in my topic today is ethical challenges. As I told you, I'm not going to cover the guidelines, etc. That will be another speaker's domain. I'll talk about the issues and challenges that we are going to face now, are facing it now also. The telehealth is not only technological improvement, but a re-engineering of the healthcare process. That is very, very important to understand. It has completely disturbed the entire system, entire milieu of the healthcare delivery systems. And is requiring consideration of socio-technical aspects of the design and development. Some questions whether this is new model of medical attention is clinically effective and provides positive outcomes for the users. That also becomes very, very important. My previous speaker spoke about that. This outcome analysis needs to be done. Both effectiveness and ethics of such services are still to be proved. Let me tell you, we talk so much about telemedicine and telehealth for decades now, 2 decades, almost more than that. Till now, we don't have a control kind of studies. You not find very few control studies. Not many control studies are there to prove that telemedicine is effective than the face-to-face medicine. Little time was left to avoid adoption before thinking through moral applications. What to talk about morality? When total lockdown is there, we just need to talk to somebody. So there's no question of ethics coming to the picture. So they don't get, system doesn't give you time to really analyze or do evaluations before accepting it in a system. Now, home-based telemedicine is being driven by economical and technological criteria with little attention to its ethical appropriateness or justification. The need of development of framework and guidelines through recent discussions before technology becomes too entrenched to be able to effect changes. That will be talked about by Mr. Ganpati later on. Some of the guidelines are available with us now, so they will be talking about that in detail. Now, I'm using the word tension. There are really ethical tensions surrounding telehealth technology and practice. Common ethical concerns are privacy, security, confidentiality, and information accuracy. All of us know about it actually in a day-to-day practice, our records, etc. But we never address that the issues of design. We design a telehealth system, we never take into account the stakeholders. The design is done by the engineers, the software developers, not by the policymakers, not by the patients. They're not involved at all in this. Neither the doctors are involved also. Evaluation issues in telehealth and clinical research are very, very important. We make a product, give it to the doctors to evaluate. When is the time to evaluate that? Individuals using technologies has to have informed consent while they're enjoying the autonomy and empowerment. Today, anybody has a mobile phone, they have the access to anybody and they can use any kind of medical records and exchange that you have seen again during the corona crisis. Relationship among various individuals involved, such as patients, providers, caregivers, and people within the patient's family are also very important. Even while you're talking to your patient, you don't want that patient relative to there. You do not know what kind of equation they have among themselves in the family. But you want somebody to be standing there, along with that. So that is also very, very important. They're small issues, but they're very relevant. At the same time, societal and policy issues also has to take into account while talking of ethics. Now, ethical issues concerning design. I'll touch upon very few things in this aspect. Conflicts between various aspects of technology usage and such as ethical principles as abridgment of privacy, including combining and mining the data. You said the data, a lot of actions are happening. What is happening to the data, you don't know. You must have faced this crisis in recent times where there are a lot of issues are concerned in newspaper about data breach. So many social media things. And the data privacy rules could not get approved in the last parliament session. It's already now. And it's very important to know that is it really accurate? And is it obsolete? Or is there any security breaches are there in that? Now, at the same time, so much of technology gives you opportunity. There are a lot of information overload. I'm just giving an example. Some relatives send me documents relating to COVID patients. It is covering so much of space in my telephone. I have to immediately erase it. It contains the CT scans, it got so much of reports, etc. So many things, prescriptions. It don't require all those things, but it has been sent by the patient. You cannot ignore it. So a lot of information overload. How much is usable and how much user friendly, that needs to be decided. Data standards is maintained or not, and integration of or linking of patient and personal information to achieve interoperability. You have to exchange when you did the healthcare organizations, healthcare individuals. For records exchange are again, there are tricky issues of standardizations, and at the same time influence the personal health management and public health. And how new applications fit with the changes in the healthcare delivery and health information infrastructure. That is another issue. Now, all these things are not theoretical now. All these things, all of us have experienced in the last COVID thing. It is all ongoing also, COVID crisis. The quality and accuracy of online information also is of deep concern, which various honor codes and vetting mechanisms have evolved to help ensure it. Whether individuals would use technology or whether or not it is usable or obtrusive. How much are actual users involved in the user-centered and user-friendly design approaches to telehealth applications? This all needs to be considered about that. Now, ethical concerns related to applications. Informed consent, of course, all of you practices. Now we're empowering, at the same time giving autonomy to the patients as well as the caregivers. That also needs to be seen, that how much it is ethically controlled. Changing relationship, we have found that we have got different kind of relationship now. Any patient can contact any doctor. Societal issues are there. Specific care domains, the ethical issues are different. Telenursing, mostly for home care. Acute versus chronic care. Internet of Things and cloud-based healthcare. This is now the common technology that you are following actually. So there also many things are now subjects of concern. Then when talking of fee for service, and fee for service brings the third party also into the picture. So there are issues in that. When you take money, then you are bound to some of these regulations, rules, and legal issues. In the area of the e-learning, in the area of education, in the area of telementoring and teletrainings, there are also a lot of ethical concerns are there. We previously used to practice sharing live surgeries to our remote learners. Now, Minister of Health has given a strict instruction, no live surgery can be shared. You can capture the video, edit it, and post it in the portal, not live surgery. And all of us has really heard about the news where in AMS Delhi, there was an incident where a patient lost during the surgery. So these are issues also have a lot of ethical concern. Now to conclude, the need to broaden and deepen understanding of how to use the technologies that have so much to offer for improving both health and well-being. Need for evaluation of these technologies that addresses their ethical and societal aspects, thereby adding to the thoughtful considerations and colleagues' call for finding ways to use the new technologies to benefit patients and practitioners while avoiding potential pitfalls. We have so many questions without answers yet. So thank you very much for your kind attention.
Thank you, Professor Mishra. That was indeed a very nice talk. Thank you for bringing out the differences between telemedicine and telehealth. That is also very important to understand. The other thing which we need to understand is, apart from the principles that are always applicable, that is related to patient care and to healthcare, there are many other issues which have to be taken into account as far as telehealth and telemedicine is concerned. Thank you, sir. We now move on to the third talk by Professor K. Ganapathy. He will be talking about the ethical guidelines for telehealth practice. I request Professor Sk Mishra to kindly introduce the speaker, Dr. Ganapathy.
Yeah, Professor Ganapathy is basically a neurosurgeon, and he is MCH as well as PhD in neurosurgery, and he has been a long time in academic environment. After that, he was a neurosurgical practice in Apollo, and later on, he also became the Apollo Television Network Foundation chairman, and he has been there in the capacity for many years now. And he has enormous contribution to the field of telemedicine, digital health, and e-health, whatever you say that. Besides, of course, his neurosurgery. He has been publishing regularly. Even last month also, I have some publications from his side. He's very active in that, and he always promotes academic telemedicine. Besides that, he has deployed many telemedicine projects, very far up places, remote places in the mountains, hills, everywhere. Very wide experience in the field. And at the same time, he was also very active in promoting Telemedicine Society. He is a past president of our society and one of the founder members of our Telemedicine Society of India. So the brief introduction, I request Professor Ganpati to give his presentation.
Thank you, Professor Mishra. I hope you can see my slide. Now, I'm going to talk on a totally different aspect. First of all, I belong to the BC era. When I say BC, I don't mean before Corona, but I mean before computers. I was the last neurosurgeon in India who was trained when there was no CT scan, when there were hardly any computers in hospital care. So far as telehealth is concerned, I believe that healthcare ethics is related to medical and healthcare decisions taken during the delivery of technology-enabled remote healthcare. I think these 4 words very clearly decide what exactly is telemedicine, technology-enabled remote healthcare. Now, we need to think of the future. I could not have dreamt even 5 years ago that there would be a full 90-minute session dealing exclusively with ethical issues in telehealth. And I wish to congratulate the organizers. I have given so many talks in the last 21 years, but this is the first time there is a full session on this. And I think this shows that the time has come. Let's spend a minute looking at how the world will be in just a few years from now. This is a slide from the World Economic Forum, an interview of 800 leading technology executives all over the world. 10% of people wearing clothes will be connected to the internet. 90% of the population with regular access to the internet. And believe me, all these predictions was before the COVID pandemic came. So the presence of the COVID pandemic has only accelerated all this. And I am certain that in my lifetime, I will see that digital healthcare has probably taken over brick and mortar hospitals. I was astonished to see that there were 1,635 PubMed index papers when you do a search only with the word ethics and telemedicine. And if you look at the graph on the left-hand side, you will see that 90% of these papers have come in the last 24 months. I was, of course, very pleasantly surprised to see Vinita Agrawal and Kishore and Saroj Mishra's papers also mentioned in this. So this clearly shows that ethics and telemedicine has now been recognized as a distinct, shall we say, special discipline within the broad area of telehealth. It was amazing to see the number of programs, webinars, of course, most of it outside India, particularly in the United States, the number of editorials, the number of review articles written on ethics and telemedicine and telehealth. This was indeed a tremendous experience for me. One of the slides which I showed here, pictures I showed here, have been emphasizing what I have been repeatedly stating over the last 2 decades. I am convinced that technology is a means to achieve an end. Technology should not be considered the end in itself. As a neurosurgeon, I always remember what Lars Lexell, the inventor of the gamma knife, which at that time was the most sophisticated technology in healthcare, he said, I quote, "A fool with a tool is still a fool." I think it is a human challenge of telemedicine. It is a man behind the machine that decides when telemedicine or telehealth is to take off. I am convinced that in spite of 4G, 5G, 6G, and 7G, if telemedicine is really to be incorporated into the core of the healthcare delivery system, our brand ambassador should be the beneficiary. How many times has the beneficiary, a patient, gone away saying, wow, that was amazing. I could see no difference at all between the person holding my pulse, looking at me, palpating my abdomen, and what I saw on this giant screen. What an effect it was. This is something which unfortunately is not stressed upon. We are experts in technology. We talk about legalities. We talk about regulations. We talk about everything excepting the human touch. I believe that ethics, I like the word professional ethics, which the previous speaker used. Let us be very honest. All of us know whether what we are doing is ethical or not ethical. You do not need definitions. A bench of the Supreme Court said 2-3 decades ago, they said, obscenity lies in the eyes of the beholder. This is what the Supreme Court judgment said. And I similarly think that we, in our heart of hearts, in our conscience, I know whether what I did was ethical or not. Coming back to ethics and telemedicine, we have already dealt with confidentiality, privacy, security. Quality of care should not be less than that of a face-to-face consultation. And of course, we need to protect ourselves from malpractice. I understand the first case was already filed a couple of months ago with a movie star where telehealth, not confining to what was passed in the regulations, is actually the first malpractice using telemedicine has already become a reality in India. Informed consent, I'm not going to deal with this. I'm going to spend the next few minutes on talking of doctor-patient relationship virtually. First of all, I am convinced, as most of us are, that in the future, brick and mortar hospitals are going to become less and less. We need to double our doctors, triple our nurses, quadruple our paramedics, and no less a person than the chairperson of the Apollo Group, 70 hospitals, 10,000 beds, etc., has publicly mentioned that the Apollo Group as such is not going to have further new hospitals, merger and acquisitions, build 500-bedded hospitals, etc. Instead, they are going to develop 100, 200, 300, 500 satellite units over tier 2, tier 3 cities, which will be linked to the main hospitals. And this is going to be the future, whether you like it or not. As I mentioned in the very beginning, though a technology buff, I still belong to the good old-fashioned doctor. I believe that clinical telemedicine is important. I believe that clinical wisdom should be contextual. And I'm very happy that in the regulatory guidelines of the TMC, it has again and again been repeated that everything is contextual. What is to be done in a telehealth consultation at that time, at that place, for that patient, by you, from where you are, taking socio-economic picture and specific requirements for patient and the family at that time. I always try to find out why the patient wanted a teleconsultation. Was he compelled to do it because he had no choice because of the lockdown, or did he do it for convenience, or because he thought that teleconsultation is as good as a face-to-face consultation? Never ever get overawed by rules and regulations. Do what you think is the best for the patient, so long as you are conscience clear. At the best, you can be accused of an irregularity, of not complying with rules and regulations, but you will always be excused. Clinical judgment is absolutely mandatory. I strongly believe that the greater the technology, the greater is tender, loving care which is required. As a clinician, act in good faith. Always have only the patient's interest first and foremost. In the earlier years, when technology was not as good as it is now, on several occasions, I have very convincingly told the patient, I'm sorry, I'm not satisfied with the quality of the CT images which you have sent to me. I need to physically examine you. I need to look at your fundus. I cannot look at your fundus now. I cannot proceed with the teleconsultation. Please come here. On several occasions, I have mentioned your history is very strongly suggestive of a convulsion, of a seizure disorder. But once I brand you as an epileptic, it's very unlikely anybody will reverse the decision. And therefore, I think we need to see you here. We need to see you getting an actual fit, or you take a video, send an actual fit to me. In other words, clinical, clinical, clinical. I am an old-fashioned physician. I would still like to do a rectal examination to find out the size of the enlarged prostate. Whereas my student may be much more comfortable with a 4D pelvic ultrasound, and he may not think of putting a hand on the abdomen is necessary at all, or a rectal or a vaginal examination. Absolutely right. He is right, and so am I. So you and you alone can decide that. So what is my take-home message? That it is contextual. Everything should be contextual. I believe that ethical practice of telemedicine lies in establishing a sympathizing, empathizing with the person at the other end. Don't look at your watch. Unfortunately, in the real world, seldom of us are professionally attired when we even do a teleconsultation. All these small things matter. The light in your room, the way you look at the patient, everything is important. Internet is a powerful tool today. But again, remember, you need to convince the beneficiary at the other end that for the next 7 to 8 minutes, you and you alone, he and he alone is what you exist for. This ability to transmit your body language is, I think, one of the most important things in making telemedicine succeed. When doctors don't listen, I'm sure many of you are aware that the 6th commonest cause of death in the United States of America from 2015 to 2019 is iatrogenic disorders. More than 300,000 deaths occur every year, which have been proved scientifically is due to iatrogenic deaths. Many of the time it is because we don't get a very detailed history. There is so much of literature published on this. Look at these books, Misdiagnosed, One Woman's Tour of an Escape from Healthcare Land. The patient today is empowered. I strongly believe that what Sir William Osler said 150 years ago is as relevant today in the era of 5G. Listen, listen, listen. He's telling you the diagnosis. Teleconsultation or not, please listen to the patient. Don't only look at the contrast MRI. Don't look at the PET CT. Don't look at the angiogram. Listen to the patient. The patient is a universe of one. Build a rapport, build a confidence, build a trust. I can assure you that you will never have a malpractice suit filed against you, even if you did something wrong, if you have established a trust with the patient. In the 20th century, when I was trained, patients believed that the doctor knows best. In 2021, the patient is as much involved in the decision-making as I am. The missing ingredient in the development of new therapies is the voice of the patient. How often have we taken what the patient wants? Why should I alone decide whether the patient is going to benefit with stereotactic radiosurgery or a radical open surgery? I need to understand what the family wants. This is what is missing now. The e-patient movement will soon come to India. Even today, we have hundreds of societies in India, the Multiple Sclerosis Society of India, and so on and so forth, where patients have got together and they have shared their own notes with them. The e-patient stands not for electronic, but it stands for equipped, enabled, empowered, engaged. Today's digitally empowered patient knows almost as much of medicine as you think you know. ePatients.net is just a question of time before all this comes to India. Techno-cultural medical revolution of the millennium, request to discuss online materials is not questioning your competence. All of us have a king-size ego. Why do I treat it as an affront when the patient asks me, what about the article in British Medical Journal, New England Journal of Medicine, that editorial said that stenting is preferable to open heart surgery? Why does it arouse me? Am I the doctor or you the doctor? This was how the approach was even 10 years ago. This needs to be changed completely. I believe this is ethical issues in telemedicine. I believe that this is what ethics deal with in telemedicine. The ideal doctor is one who's prepared to lose the battle in order to win the war. Have 2025 standards, not 2015 standards. Remember that the future is always ahead of schedule. Do not try to be a perfectionist. Look at every failure as a learning experience. Today, unfortunately, the neurosurgery itself has at least 12 subspecialties: skull-based surgeon, cerebrovascular surgeon, radiosurgery, interventional neuroradiology, etc., etc. We are becoming master craftsmen, superb technicians, skilled in knowing more and more about less and less. This is not the way it should be. Yes, new skills must be acquired, but what got you here does not keep you there. You must be ready for the future. If you do not continually change, you will be history. I like this Venn diagram which composes people, technology, and process. You can see that technology cannot be dissociated with people and progress. Healthcare is something very personal. I've always stressed that it is not akin to buying a pizza online. I can book a movie ticket online. Yes, I can book an air ticket or a train ticket online. I can do a bank transaction online. But believe me, it is very, very different from doing an online, I hate the word transaction, online transaction with a healthcare provider. Healthcare is something extremely personal. You need to make an eye contact with the beneficiary. You need to introduce yourself. You need to see what they are doing, what you are doing. The good news is that excellence in healthcare is neither hard nor expensive. But the bad news is that despite that, in some places, these simple things are not common. Again, what William Mayo said a long time ago, he said, it doesn't matter if care is cutting edge and technologically advanced, if it does not take into account what the patient wants. Patients don't care a damn how much you know. They only want to know how much you care for them. The aim of medicine is ultimately to prevent disease and have a good quality of life, not just prolonged life. The ideal of medicine is to eliminate the need of a physician. About 15 years ago, Professor Kamilini Ramdas, a very well-known professor at the London School of Business, met me and asked me if I would cooperate with her and we could do shared medical appointments. I was very much interested. Unfortunately, I think Madras City or the institutions where I work were just not advanced enough to even take that. Today, she herself has published several papers, and I think this is going to be a major way in which healthcare is going to be delivered, particularly in the post-pandemic era. Bedside manner is going to be replaced with website manner. I am sure that the next generation of doctors, there are hundreds of papers already published on website manner. And even a person like me who has been embracing telemedicine, evangelizing telemedicine, I learned so much by reading these papers on website manner. So I think this is the future, shared medical appointments. American Psychological Association have already started this group therapy using telehealth. I think it makes a lot of sense. Now, I deliberately mentioned this because ethically speaking, when I was a medical student, a postgraduate and a teacher, we were always taught about confidentiality. That was a bottom rim. We were always taught that a doctor-patient relationship is sacrosanct. But today, a number of patients will be seen by the doctor in a single group. So I think this is the future, and telemedicine also, group telecounseling is going to happen. So ladies and gentlemen, the ideal clinician should not just be a tech-savvy expert. He should have the surgical wisdom of Sushruta, the compassion of Mother Teresa, the pragmatism of Lord Krishna and the Bhagavad Gita, the genius of Albert Einstein, the innovativeness of staff. In other words, he must be a superman. This is my final slide. So I think our universe has changed. India should no longer follow high standards. We should set them. We no longer should be striving to achieve world class. The world should strive to achieve India class. Nothing can stop an idea whose time has come. Creating awareness and convincing society that geography has become history should be followed. And I'm very happy and once again thank the organizers to bring a very important subject, namely deployment of ethics and trust, and add it to laws, rules, regulations, and compliance. Thank you. Sorry for exceeding by 1 minute.
Thank you, Dr. Ganapati. That was really nice. It was a wonderful talk. I hope all our healthcare professionals will have been enlightened. It was really nice. We can understand that it is more important that the person who is sitting behind the machine is much more important than the technology itself. And you have brought that point so nicely to our participants. Thank you. We will wait for the comments at the end of the session. I now request our next speaker, Professor B.N. Mohanty, to talk about the responsibility of the stakeholders to facilitate ethical practice of telehealth. I request Professor Sk Mishra to introduce our speaker.
Okay, thanks, Vinita. Professor Mohanty, whom I know more than 3-4 decades by now, he was alumni of Sk Medical College, Cuttack, and did his postgraduates in surgery in PGI Chandigarh. And after that, he was in Department of General Surgery, but at the same time shifted to endocrine surgery soon after, and he has established first Department of Endocrine Surgery in Sk Medical College, Cuttack. For the last 20 years, from 2001 onwards, I think I've been collaborating with him for telemedicine, and we have jointly set up the telemedicine in Odisha, starting from a small unit to now a statewide telemedicine network. I take a lot of pleasure of working with him. in the journey of telemedicine in Odisha. So after his superannuation, he has been appointed by the Odisha government to advise them on the telemedicine program. This is one of the states where all the district hospitals and some other hospitals have been connected with the network, statewide network, and very systematically they cover up the needs of the peripheral district hospital by adopting in a region-wise manner. Very systematically, they have gone through last 15 years in developing the program in Odisha, and Dr. Mahanti is the main backbone behind that. He also took interest in setting up a facility like us here, making a regional resource center for telemedicine in the campus of Sk Medical College, Cuttack. In that also, we take pleasure being associated with that program. So now we have a dedicated building and facilities, and we've offered them technical assistance in setting up that facility there. Professor Mahanti, I think you should go ahead, and the topic that we allotted you is to tell us how the role of stakeholders are important in the ethical practice of telemedicine. Dr. Mahanti, please.
Thank you, Professor Mishra, for your kind words. Distinguished guests, my friends and colleagues. While innovations in information and communication technology have significant potential to benefit patients, these also raise ethical challenges which, if not addressed well, would weaken the patient-physician relationship. Here comes the responsibility of the stakeholders to facilitate the ethical practice of telemedicine or telehealth. Yeah. So what do you understand by stakeholder? Now, stakeholder is any person or a party or an organization that regulates telehealth care, that provides telehealth care, that looks into the payment for delivering the telehealth care, or a person who in fact receives the telehealth care. Now, when you talk about the stakeholders involved in provisioning and delivery of telehealth services can be broadly grouped into 4 groups. You can call these 4 Ps. Now, P1 is policymaker. So policymaker or regulators are the government or the government agencies. The second P is the provider. He or she may be a healthcare provider, a technology provider, or a health institution or a hospital. Now, third P is the payer, either reimbursement by an insurance company, on an employer, or if none are available for payment, then individual. And the last P is the patient, who in fact is the ultimate receiver of the service, telehealth service, or you may call them as customers, where they pay for receiving the service. Now, let's come to the responsibility of the policymakers. Now, when you talk of the policymakers or the regulators, now we think that making legislation or preparing guidelines for effective delivery of telehealth care is the job of the government or government agencies. Now, in this country, the telemedicine practice like guidelines were notified by government last year in March. Hardly there was any time for bringing a legislation for that. So the government, because looking into the COVID-19 pandemic crisis, notified the guidelines which were rapidly accepted by many healthcare professionals. So it is now perfectly legal in India to provide teleconsultation by registered medical practitioners, MBBS or above, in line with the requirements of the telemedicine practice guidelines already notified by the government. Now, when you talk of the telemedicine practice guidelines, what does it provide? When you think of the role of the providers, Now, this provides that the norms and protocols relating to the physician-patient relationship, which are to be followed by the healthcare professional. Second is it provides a broad outline on the issues of liability and negligence. Thirdly, it looks into the evaluation, how a medical practitioner will evaluate, manage, and treat a patient over a virtual platform. And what are the methods of obtaining consent, whether it is a implied consent, whether it's informed consent or explicit consent, when the situation, depending upon the situation in which a consultation is being offered. Then also it lays emphasis on the privacy and security of patient records, which has been discussed by my previous speakers. And finally, it also looks into the scope of reimbursement and the health education. Now, National Medical Commission in India has been functioning. This formation of this was notified in Gazette on 24th of September 2020. And from next day, that is 25th of September, National Medical Commission started functioning with an aim to enforce high ethical standards in all aspects of medical services, including telemedicine services. Now, that was about the regulators or the policymakers. Now, next is the responsibility of another stakeholder, that means the medical professional. So here comes the role of the key stakeholder, that is the medical practitioner. So even if we adopt new technologies and new models to deliver medical care, but we must remember that physicians' fundamental ethical responsibility do not change, whether it is an in-person consultation or whether it is a consultation over a virtual platform. He or she is required to uphold the same professional and ethical norms and standards as applicable to traditional in-person care, what is happening for centuries. Now, next comes the fidelity, or we call faithfulness to a person. Now, we should not forget that patients and their family members, they have always faith on the physician, on the medical practitioners. And the medical practitioners who offer the medical care from a distance, whether it is a virtual consultation or in-person consultation, it is required, they have to place the interest of the patient over all other interests. That is always necessary, and the patient has a hope that the physician will do that. Now, second is the professional. What are the professional judgment? Now, when we talk about professional judgment, now it is necessary that the physician or the medical practitioners must determine what modality of care is best for a given patient. Now, if he is thinking of delivering or a consultation over a virtual platform, he should remember that if he is dealing with a patient of asthma, he doesn't know that whether it is a case of cardiac asthma or a case of bronchial asthma. So it is difficult to offer a consultation unless you know one from the other. A patient of cardiac asthma, which is otherwise known as left ventricular failure, if not treated immediately, then patient may succumb, but not a patient of bronchial asthma unless he is in status. So in these situations, it is necessary that patient has to be examined in person to differentiate whether he is dealing a case of chronic bronchial asthma, acute bronchial asthma, or a patient of cardiac asthma. Similarly, if an emergency condition necessitates urgent care, the medical practitioner has to advise first aid to provide immediate relief and guide for referral of the patient. Now, let's take for example of acute perforative peritonitis with dehydration. If a patient is there at a remote end with acute perforative peritonitis dehydration, then the medical practitioners has to look into the first aid in the form of administering intravenous fluids to correct the dehydration, and then thinking of referring. So that is essential in all emergency conditions. Now, medical practitioner has to decide when to shift the patient for in-person care or to refer. So any patient who is being offered teleconsultation and subsequently on tele-follow-up, if develops a complication, he has to be, it is the responsibility of the medical practitioner to decide that the time has come to shift or refer to a specialist which is staying nearby. Now, the privacy and confidential issues have been discussed in detail. Physicians who provide clinical service via telemedicine must protect the security and integrity of patient electronic data while receiving the data, while storing the data, and while transferring the data to other physicians or medical practitioners with whom he wants to share to come at a conclusion or to better plan the management of a particular patient, and must ensure that the healthcare professionals also at the remote end with whom he is sharing the patient data behave also likewise. They have to also store the data in the way the primary physician is looking after. They must ensure appropriate mechanism to prevent unauthorized access by third person. Now, next is with continuity of care. Now, physicians who provide clinical telehealth or telemedicine services must not abandon the patient and should possess the commitment to provide for continuity of care. Now, this is more essential for non-communicable diseases, particularly for patients with orthopedic problems, rheumatological problems, diabetes, hypertension, chronic kidney disease, and so on and so forth, where continuity of care is extremely essential. Also, the patients of cancer who have been operated and subsequently are on follow-up. Now, next is the responsibility of the health institutions or the hospitals. Now, we talk of the government hospitals, the private hospitals. Now, the hospitals should have some control over the medical practitioners. It is essential always that the private hospitals, who is possible to have better control about the health practitioners than government hospitals. So whatever may be the situation, it is essential that the medical practitioners should not be allowed to insist on teleconsultation, where patient's choice is for an in-person consultation. It is also the responsibility of the hospital to see that the medical experts are not permitted to upload images and pictures of patients on social media. A strict vigil is to be maintained to see that the medical practitioners do not prescribe drugs from the restricted lists, and instructions to the medical practitioners has to be issued to see that they do not solicit patients for telemedicine through advertisement, which has been discussed in detail by Dr. Sunil Shroff. Now, let's come to the responsibility of the payers. Now, friends, the Insurance Regulatory and Development Authority of India has directed insurers to include telemedicine as part of medical consultation cover in health policies. This was done after Medical Council of India issued telemedicine practice guidelines in March 2020, enabling doctors to provide telehealth care using enabling doctors to provide healthcare using telemedicine. So hence, all policy holders are now eligible to avail this facility as part of claim settlement policy. So this is definitely a facility which have been given to the patients. But friends, it is expected that the insurers would find ways and means in coming days to scrutinize better the claims so that some ethical aspect is enforced. Now, as regards the responsibility of the employer when do not have the reimbursement facility by the insurer, then it is the medical grants which are given by the employer. Indian organizations are fast turning into telemedicine as part of their employee health programs after the IRDAI mandated health policies to cover telemedicine consultations. But friends, look at this, that telemedicine provides employer short-term savings. So why short-term savings? Because the reduced cost of telehealth care claims resulting from employees' unnecessary trips to a doctor. So earlier, the employees were being referred to different hospitals for which they used to claim the travel expenses. So the employer can get rid of all this if the employees take the advantage of telehealth care. But is it always should be enforced? Should the employers to do this always? So can the employer ensure ethical telehealth practice while looking into the savings that which goes to the hospital administration? Then responsibility of the patient. Ethical issues in telemedicine implies a consideration of patient's benefit or loss in receiving telemedicine services and his or her right to choose the therapy and react to dissatisfactory services. That means the patient has the right to choose the physician and he has the right to withdraw treatment during the process of tele-follow-up from any medical practitioner he is not or she is not satisfied with. So that is always there for benefit of the patient. The patient shall be responsible for accuracy of information shared by him. So it is essential whether the patient is sharing or a caregiver is sharing or a healthcare worker is sharing for the patient. Now the data has to be accurate, should be informative, so that the medical practitioner can make a proper diagnosis, or if required, we can ask for additional information, additional tests, so that proper diagnosis can be reached by the medical practitioner and proper treatment can be advised. So friends, to conclude, I would like to say that stakeholders have to play a critical role as regards facilitators to promote the ethical practice of telehealth. Ethical guidelines in telemedicine are expected to complement the quality of healthcare services and strengthen the doctor-patient relationship. Thank you all.
Thank you so much, Professor Mohanty. That was a really nice talk. You have efficiently summarized the rights and the responsibilities of all the stakeholders. That was really nice. We have some comments in the chat box. I think we can now address the questions or the comments. So Dr. Sunil Shroff has, his comment is related to the draft of the version 2, which will now be there for the telemedicine practice guidelines. So he is asking that what areas need to be addressed. That is an open question. And then also there is a follow-up question about the NMC ethical guidelines on advertising and telemedicine ethics. What is the view of the panel on the same? So one is related to the new version, that is version 2 of the TPG, that is the telemedicine practice guidelines, which were issued in 2020, March. And the second is related to the NMC ethical guidelines about advertising. Dr. Mohanty, Dr. Krishnan, would you like to answer the queries?
Can I make a comment, Ganapati here?
Yes, Dr. Ganapati.
Dr. Shroff, I agree with both the points you have raised. And as you know, it will take at least 18 months to 24 months before even if we start work today, before the version 2 actually becomes law. I think this is a great opportunity. Maybe the ethics committee of SGPGI could and TSI could take the initiative. And I would strongly suggest we develop a committee which we meet once in a month or once in 2 months. This is something which cannot be answered in a webinar over a period of 10-15 minutes. We need time to think about it, deliberate it, do a lot of homework. There's no point in reinventing the wheel And even when I was just going through, I found hundreds of articles in PubMed Index journals and other things. I think it's a good idea. Both the topics, I totally agree with you. And my suggestion is that we should do it formally, maybe meet once in 2 months, keep 6 months as a deadline before we get everything ready and submit the proposal. And if you really pursue it, like the way Sk Mishra and you and all others have done in the Vahanti and all others have done in the past, hopefully by 2022, within the next year, we should get version 2. And I think version 2 is absolutely necessary. We have learned so much by getting into the water. You know, you can't learn swimming with a postal course. And in the last 15 months, we have picked up so many things which even those of us who have spent a lot of time were not aware of it. So this is my suggestion.
Thank you, Dr. Ganapati. Dr. Mohanty, do you have a comment related to the remark?
I just want to say that the telemedicine practice guidelines now lists that you have list O drugs, list A drugs, list B drugs, and so on and so forth. Now, what happened during COVID-19? Now, during COVID-19, a lot many drugs were used by medical practitioners. Do you think that there was any hold by any regulatory authority on use of those drugs? Did anybody did they prescribe they advise that these drugs to be used? These drugs were used by most of the hospitals. I do not want to name those drugs which were used for treatment of COVID-19 by the medical practitioners in different hospitals. Nobody had any control on that. So how far we are justified to only say that these are the drugs that were prescribed during teleconsultation and telefollow-up, and what happens during emergency? Do you think that we can be given some freedom during emergency, during these public health emergencies, that we can prescribe drugs as we think they are suitable for benefit of the patient?
I just want to add, Sunil, I think very nice that you raised this issue. You have raised this issue on several occasions. Several other members also in different fora also have raised this issue. I think we should all realize that the welcome step is first the guidelines was launched, right? Earlier, we have been tried many years. Ganpati must have been there also, you know very well. So in earlier years, we have tried a lot. At least we're happy that the guidelines are in place. And all of us know, Sunil, you also know very well, it was launched in a hurry. It is not in a hurry because that was the time where COVID was already set in. They wanted something. Though we tried for that. Before COVID came, our group has started, the Telemed Society members, the group has already tried activities, document preparation, and you have legal consultants also, the DSI groups. So all the things all of you are witness to that actually. So definitely that acted as a binding force for the Niti Ayogs to take it up. And I think COVID acted as a force multiplier. I think Sunil will agree on this point. It has acted as a force multiplier. They have to do it. There's no other option left actually, right? So when something happens in a hurry, then many things are left out. And if you remember, Sunil, actually, none of us are even called when the final draft is made. You know very well. Our document, many things are not taken up also, right? So at the same time, they also agreed to our suggestions. If you remember that when it is discussed with gentleman there, Mr. Paul, he also agreed. Definitely, whatever points they are saying, there is a substance in that. Definitely, we'll go to it later. He also accepted. It was done in a hurry. So there will be a lot of open space to debate further. So that's why what I am thinking this time, actually, I discussed with Dr. Pradhan, the organizing secretary for Telemedicine, that we'll dedicate one particular session for 2-hour session for an open house discussion. It's an open house completely. Let everybody say whatever they want, right? And Sunil, I think you and other people who are you are all very active in this TPG guidelines, training, etc. You can take it lead and organize this group. So we'll give a time slot on behalf of the society. You can address this thing, and you already have so many points listed already. So now let us take the open house opinion and make a document and send it to Niti Aayog as well as the Medical Commission. And the National Medical Commission goes as per the recommendation of the Niti Aayog. It is just a kind of platform where it is launched. Other everything was done by the Niti Aayog. Point number 2, I want to add one thing, Dr. Sunil, that there is another groups also. There are several other groups are also working in the guidelines. Homeopathic, Ayush, there are several guidelines available. There is another group also who is working in the Bangalore, that is called the Disease Informatics Group of ICMR. They have developed some guidelines for chronic disease management. And being an organization supported by the ICMR and ICMR organization, they also claim that these guidelines also has to be there. So I think we are also inviting them also this time. So we all will sit together. There will be homeopathic, IOS, as well as the chronic disease group from Bangalore, and also our group in TSI. And we'll have open house, we'll have adequate time. We'll plan it much in advance by talking to all the stakeholders. So let us make it in a planned way, make the agenda in proper manner. And we'll debate all these points you know are very well. At least you have shared this group. I'm happy about that. So it's already in our mind for Telemedicine 2021.
Thank you, Dr. Mishra. That will be a really nice attempt to have those guidelines if everyone comes on the same.
I just want to ask Dr. Mishra, sorry to interrupt you, but I want to ask Dr. Mishra, when is the Telemedicine 2021 in Lucknow? What are the dates?
The dates are 12, 13, 14. The website is getting launched, I think, by early next week. But dates are announced before. It is communicated to the executive committee as well as, I don't know why they have not announced it. So it is already there, and we'll, the website is already launched. You can see the announcement at least. And the content is getting hosted by tomorrow or day after. Sorry, Monday or Tuesday. It's 12, 13, 14. Friday, Saturday, Sunday. And what we plan actually to have a dedicated announce much in advance. We'll make the groups, which very systematic way will go, like Dr. Kanpati has said. So we should prepare a white paper and give it to the. But only thing is, let us avoid a lot of conflict. There are a lot of conflicts in different groups. In our country, we talk about holistic medicine. Now the present government is very much into that. Holistic medicine, integrated medicine. So these are things going to lead to confusion for us. So we have to address those things. They want the homeopathic, allopathy also should be part of this healthcare system. They work in an integrated manner. So how we are going to integrate these guidelines to that, that also needs to be addressed. We'll talk about that when the time comes about.
I completely agree with the alternative medicine being included or not included, and what are the guidelines for those areas is something which needs to be pondered upon. The other thing which I was just wondering, Dr. Mishra just referred to it, what is, we say that these records have to be kept, but nowadays because of the COVID-19 pandemic, a lot of consultation is going on WhatsApp. So what is, do we have something that how these data have to be preserved, the communication between the patient and the healthcare provider, because they're posting a lot of pictures, they're posting a lot of images and all whatnot. So what do we have something constructive, or do we need to keep it for 3 years? All of it is not very clear in the guidance.
Very nice, Dr. Rajit. I'm very happy that you raised this issue. All of us know. Let me tell you one thing. TPG is one side and the COVID is one side. So, Ganpati, I think you'll agree with me. It is as you always say BC. The BC is not before Christ. It is now before COVID and after COVID. And COVID will become a landmark watershed in the history of telemedicine in the entire world, not in India. So I think people want to do research on telemedicine. Hundreds of theses can be written on various aspects of the telemedicine during COVID. We don't know actually. You don't know the answer what Dr. Pinta has asked us. You don't have answer. We're desperate attempt. It's just like in flood, we are just flowing out in catch all of some tree, like that only. We all know about it. Telemedicine has made us to survive and made us to contact somebody who can talk about something. And all of you have also contacted to one of your relatives. And many of the relatives, you have made them COVID expert also. So fortunately, those relatives have become another mentor for other relatives. So what has happened during COVID time, nobody has expected. How the telemedicine has done, nobody expected. But what is, we know, everybody has known what is telemedicine. Everybody knows. Small boy to the elder person. You don't have to tell them. All these 20 years we have been struggling to tell people, tell the policymakers, tell the colleagues, please practice telemedicine. Overnight, the entire world has changed. Without any spending a single pie, without spending energy. Ganpati, I think you agree with me.
Yes, absolutely.
More specifically, on Vinita's question, as per the guidelines of WhatsApp, you have to preserve the transcripts for 3 years if it's WhatsApp consultation. Because if you look at the guidelines, and if you take all this, it very clearly says that as far as videos are concerned, you need to only preserve the logs. But as far as the transcripts are concerned, you need to preserve them at least for 3 years. So whether it is WhatsApp or whether it is any other application, you need to keep those transcripts for 3 years for you to be safe as a practitioner. And if it's a medical legal case, it goes to 10 years.
Dr. Sunil, just to add a point, in the real world, irrespective of laws, unless a test case comes before a court, and even then the interpretation, we all know a magistrate says something, the higher court overrules that, a single bench overrules that, and 5 different decisions are given in the higher courts. So one way to what I have been mentioning, nobody, I mean, in 45 years of my neurosurgical practice, by God's grace, I have not had a single court case. Not because I have not committed mistakes. Yes, I must have committed mistakes which could have gone to court. But it entirely depends on the doctor-patient relationship. Unless you irritate a patient, patients do not go to court just because a person dies or just because a hand is amputated or becomes paralyzed after the treatment. He goes to court because you have irritated him, because he's angry with you, because you did not communicate with you. So I think we need to emphasize this. I mean, I agree it's important, we need to preserve, etc., etc., etc. But simultaneously, believe me, nobody goes to court just because of a bad practice. It's entirely because of horrible, faulty communication.
Yeah. Absolutely. There's a subjective aspect and there's an objective aspect. And you're absolutely right on the subjective aspect that, unless somebody is irritated, obviously, he will not do that. But to give it a very objective kind of picture so that, there is a general rule. This is what the guidelines say is according to what I have told you.
I think I request our chairman of the IC,
Yes.
Dr. Mr. Nath, and all members of the IC who are here. Sir, I think you will be getting some of those projects now to address some of the issues in telehealth. Maybe some research projects will come in the near future. I think it's very important that they should also know about the entire ecosystem of the telemedicine, digital health, all those things. In the near future, you are going to face some of the projects to review. Many things you don't know. So, yeah, please go ahead, sir. Prasanna.
Well, as it was told by the speakers that it is a legitimate practice, it is approved by the government, it is as permission telemedicine. So if someone approaches for a medical research through telemedicine, we will accept, because it is now by law it is acceptable approach for the treatment of patient. And since our ethical committee is related with the biomedical research, so if someone proposes a proposal or research through using telemedicine, it will be acceptable. Providing
actually out of domain of telemedicine at the moment is an exclusion.
Yes, no?
In fact, just to add that we have been accepting consent forms through the tele methods. So now with the COVID pandemic, we have already been on the front foot trying to accept those, provided the PI tells us how they want to do it. So in those concerns, if there's no concern, so we just give an ethical clearance for that also.
The actual research, that means they say clinical trial of drugs and so on, will not be allowed using telemedicine. You can accept a proposal of research through your, the telemedicine. That's more on an education side. But as an actual research on the ground, at least at the moment, in the purview of the telemedicine practice guideline is excluded, including remote surgery.
The guidelines neither endorse it nor does it repudiate it. It's silent on this subject.
Doesn't cover it excludes it basically. It very clearly defines that.
Now, but at the same time, and Sunil, I think you will realize that when you go for evaluation-based studies in telehealth, so you have to go to the interview of the subjects. I think the ethical element has to come there.
Yeah, absolutely.
So we have not really addressed that. Not many projects have come through the ethical committee. That's why I specifically requested to Sansannath to get apprised about this thing. In the coming years, they may get here or anywhere in the country or world. So you are going to involve the patient. You're going to involve the records. So we cannot just escape from the ethical aspects of the telehealth research. The point number 2 I want to say to all of you are, again taking the question of Dr. Vinita forward and the comment of Dr. Sunil Rao. See, we have to address the digital infrastructure of the medical institutions. That is one thing I think we have to totally forgotten about that. Because as a kind of desperate measures, we just attempted a transaction. But the TPG says that what you said in response to Dr. Pinta's question. But let me tell you, I don't think any one institution has ever saved the WhatsApp messages. And all of us know the Delhi ward rounds have been done through WhatsApp videos. Delhi ward rounds are done remotely. Delhi ICU rounds are done remotely. Nobody goes to the ward to see the patient. Junior most doctors are there in the bedside, or nurses are there. All these things are not recorded. And at the same time, let's forget about the COVID. Even post-COVID also, whenever telemedicine going to telemedicine going to stay. Post-COVID also, we have got a hybrid system. All of us know about it. But let me tell you, except that the transaction platform, we do not have back-end support. So here is the question of maintaining records. The TPG is there, but government organization doesn't have money to take a license from the cloud infrastructure to store our medical records. We do not have digital strategy for medical institutions the way the Western countries have gone there. Number 2 point, all of us should know about it. The Data Privacy Act is already in the horizon. It could have been approved in this cabinet meeting, this parliament session, but it could not be done. But once that is there, it's already there in other countries. Whenever you send a paper publication, they always ask these things. So once that comes, we all are bound to have the digital infrastructures. Now, currently, how many institutions have a hospital information system? Very few. So this is a very big issue in the future of so-called digital health. In broadly, I'm taking it beyond telemedicine also. Digital strategy for all institutions.
Mishra ji, if I may just make one remark, I do not know about SGPGI, but I do know that AIIMS New Delhi Neurosciences Center have conducted the DM exam, MCH exam, and DNB neurosurgery exam with the examiners appearing on a video screen. Patients have also appeared on a video screen, and papers have been published. I reviewed some of the papers, so I don't know about SGPGI, but this has become a reality. MCH DM exams.
It happened all over the country, sir. This is a National Medical Commission guidelines.
Yeah.
Right. So for last 2 years, last year also, this year also, right? So we have seen several evolutions in the exam systems in last 2 years, and it's good to happen. At least let the regulators realize we can maintain secrecy, we can maintain the sanctity of the exams.
Thank you. I think that is a really nice discussion. We also have the program being linked on the YouTube, streamed on the YouTube, and being attended on the YouTube. So that was a really, do we have any more comments or any questions related to the topic? So with that, I think telemedicine and telehealth services are here to stay. And we will have more and more guidelines and things coming up in the next few years, thanks to the COVID pandemic. And as Dr. Ganapati said very rightly, we need to understand and learn the website manners. I think with that note, we can end this meeting. Thank you so much. That was really nice.
Thank you very much.
Thank you all the faculty experts who have agreed in short notice.
Thank you, sir.
We'll catch on and we'll continue. It's a preparatory meeting for our telemedical on the same topic. Okay, thank you very much.
Thank you, Dr. Ganapati, Dr. Shroff, Dr. Mohanty. Really nice of you.